So we'll have Dr. Vardhaman Kankaria, and he needs no introduction. He's going to talk on post-refractive surgery biometry. Dr. Vardhaman.
Thank you so much, Dr. Bella sir and the whole team, Dr. Namrata ma'am for the kind invite and the opportunity. So friends, what I'm going to talk to you about is something which is extremely relevant to each one of us today, because this is about something that we are going to see more and more number of patients coming in for our clinics. And we all are going to be dwelling with these issues of biometry after they have undergone their previous refractive procedure. Friends, we know that it has been almost a century before the first ever attempt of corneal refractive surgery was done by Professor Sato in the former posterior RK about in 1920. And from that time to current generation of laser refractive surgeries, we have truly come a long way. But I think this was in 1990 when the first global phenomenon of acceptance of corneal refractive surgery happened around the world. And this is when the patients actually tested the miracle of this amazing, miraculous procedure which can get rid of your glasses without any pain, without any not much post-operative recovery time, with a great amount of wow effect, and this became extremely popular around the world. And so far, multiple millions of people have undergone LASIK surgery in the world. Now, the first generation who had actually tested the success of this miracle was what is called as the baby boomer generation. This baby boomer generation as of today are the same people who have become 60, 70-year-old, and they are the ones who are coming back for their post-LASIK cataract surgeries, and they are the ones who have a extremely high, unusual expectations. They have relatively low intolerance for diminished vision. They are the ones who will request you for early cataract surgery, and they will be very demanding because they have tested the accuracy of LASIK, and they would like their cataract recovery to be as good as LASIK procedure. However, the issue is that in the very patients who desire the most accurate post-operative refractive results, the IL calculations are unfortunately least predictable because of variety of factors which happen in the form of 3 different errors in calculating the biometry. Before we go to our current generation formulas, let us understand how the biometry works in virgin eyes. We all know that when it comes to virgin eyes, there are 2 different generations of formulas. The first one is called as the regression analysis, which is dependent on the accumulated data. And the second one is more recent. It is more predictable. This is what is called as the theoretical formulas, which work on the principle of what is called as effective lens position. Effective lens position is the difference in millimeters between your anterior refractive surface of the cornea and the nodal point in your crystalline lens, or the IOL which is going to go inside and sit in the back. It was presumed in the past that this effective lens position will be 4 millimeter as standard, but then it was seen that in shorter eyes, the ELP is shorter, of course, and in the longer eyes which are myopic, the ELP is going to be longer, and this had to be counterfeited, this had to be adjusted. So this prediction of the effective lens position became the cornerstone of the accuracy of the current generation formulas, and these all formulas depend on more than one parameters to predict ELP, as we have seen. Now let us see how and why the IL power calculations are different and more difficult after their excimer laser applications such as PRK or LASIK. So there are 3 different sources of errors which happen. Number 1 is called as the index of refractive error, that is calculation of K reading. Second one is the measurement error, that is on topography and keratometry you have errors because of the previous LASIK surgery. And the third one is the prediction in the ELP, which happens because of the errors in the formula in itself. We all know that whenever we actually want to understand the diopteric power of the cornea, this is a very specific equation, and the ratio between the anterior and the posterior surface of the radius of curvature of our cornea, which has to be maintained at 1.21, and that is the whole basis of the calculations of keratometry in our current generations. However, when you undergo LASIK surgery, we know that the cornea on the anterior surface becomes flat, so there is going to be overestimation of the keratometry, thus causing underestimation of the IOL power, leading to hyperopic surprises in patients who have undergone a myopic ablation in the past. And opposite to that, if you have undergone a hyperopic ablation, the cornea becomes steeper, so therefore your keratometric prediction becomes underestimated, your IOL power becomes overestimated, and therefore you land up in having myopic surprises after your IOL calculations in cataract. Second one is the topography or keratometric measurement error. We all know that the most important point in keratometry is the central point, this one. But majority of these keratometers and topographers actually do not calculate the keratometry in the apex of the cornea or the center of the cornea, but it does it at the zone which is 3.2 millimeters away from the center of the cornea. And the second one and the third one, of course, is going to be the prediction of the ELP errors which depend on the formula. We have all seen that these ELP prediction models work on variety of parameters which had to be utilized to get to a good IOL power calculations, and all of them except for one depend on keratometry as a prerequisite. So if you look at all this keratometry, wherever you're using this keratometry, and because the keratometry calculations are going to be erratic, you're going to actually have a lot of surprise also in the formula. But when you use the Haigis formula, you see that Haigis does not depend on keratometry, and that's the reason that in Haigis you actually still achieve a good outcome with post-LASIK situations. So generally what we have seen so far for patients who have undergone a myopic treatment, they will have a overestimation of keratometry, they will have an underestimation of ELP, leading to underestimation of IOL power generally. And the hyperopic patients who have undergone LASIK in the past will actually have an underestimation of keratometry, overestimation of ELP, leading to overestimation of IOL power in general. So when we understand that these are the errors, how do we still go ahead and calculate the lens? And as we have lens power, and we have seen already that the Haigis L formula is K independent formula, and that's the reason that you can still go ahead and use a Haigis L formula if your biometer has the direct access to Haigis. But if your actually biometer utilizes the other keratometry driven formulas, then you have to go and use what is called as the Arambedi double K method. This Arambedi double K method uses two different keratometers. Number one is the pre-operative keratometer determination that is used to predict the effective lens position, and the true post-operative keratometer measurement is done through pentacam and to be used in formula for calculation of IOL power. And when we use this Arambedi double K method, definitely you achieve a very, very predictable outcomes. There have been variety of formulas. We have used these two different approaches, and they have seen almost equally predictable outcomes, and they all have been coalesced together in this wonderful website on ASCRS online calculator. And all of you can go there, you can put the type of refractive surgery that has been done on the patient, any pre-operative or current data that you know already about the patient, you can enter that as well. The IOL power is calculated by a variety of these formulas, and those requiring also historical data, and those do not require historical data. And it will give you three readings. One will be minimum, one will be average, and one will be maximum. And that is what you have to utilize. There have been a lot of different studies which have looked at all these formulas, and they have seen currently the OCT based and the True K methods, which is by no history, are currently one of the best formulas which are used currently. With all these things in place as well, unfortunately, the patients who have undergone RK and PRK are still getting good results, but the patients who have undergone radial keratotomy do not achieve good outcomes because they have also a lot of corneal instability. And in spite of the best analysis, we have seen that only 65% cases are plus minus within 1.5 diopters. Let us look at this case in which we can see the cornea is very, very flat. The patient has undergone a 16 incision radial keratotomy. The keratometry has dropped to 29 diopters. And you can see on the IOL master, the calculations are varying between almost 17, 18 diopters to 19.5 diopters. And this is a nice method that I use. This is called as a Maloney's method, in which you can do the intraoperative retinoscopy and then have a multiplication factor to come to your IOL power. And in this particular patient, we actually could come within 1 diopter. And so far, we have done 38 post-RK patients with the same method and achieving 90% of our eyes plus minus within 1 diopter with this technology. We have also seen that if the patient has undergone previous intacts because of the keratoconus, you can still go ahead and use the post-myopic formula on the ASCRS. And the most important thing is that for the patient who has undergone a phakic lens implant, you do not have to make any adjustments whatsoever if you want to do biometry for these patients. So that is the crux and the simplistic approach to these patients. But for sure, I do expect more and more of us are going to come ahead and they are going to do post-LASIK keratometries and biometries in the future. And I hope that this helps all of them. Thank you. I think we would like to know the comment from Dr. Harbansh also. Thank you so much.
One of the most elaborative, topics in ophthalmology, and 10 minutes don't do justice to it, but you've done so well.
Thank you. Thank you so much.
Yes, sir, please.
So I think there are two things.
Yes, sir.
One is that take the flattest corneal measurement available in all the possible equipments used,
Yes.
whether it's a pentacam and whether it's a lens star IOL master.
Right.
And it is not always the pentacam gives the flattest. I've seen patients where the lens star and IOL master have given the flatter as compared to the pentacam reading.
Right.
Secondly, in all the irregular cornea, refraction of the patient is more important than the calculation by any other machine. That means if the post-RK patient has got a hyperopia of 5 diopter, so we target -1, take it as a hyperopia of 6 diopter, multiply it by 1.7 or 1.8.
Yes.
That means when you multiply 6 into 1.7, it makes it 10.
Yeah.
21 is the normal IOL power used. This patient should have 31 diopter of IOL in his eyes.
Right.
If all other calculations, some calculations given 20, if they are coming around 31, it's fine. But anything is coming 22, 18, 16, 36, 37, you got to be very, very careful. And even for the astigmatic correction, in my post-RK patient, whatever patient is accepting on the spectacles is the more important, whatever reading you are getting on a pentacam and a biometry. So all the astigmatic correction should be done on the basis of the spectacle refraction and axis. You will never go wrong.
So I think all these points are very important, as Sir has said. Number one is that you should, if you have access to multiple instruments, it always is better because you can actually understand how the corneal keratometry especially are varying between all these instruments. If you go flatter, as has been discussed, always is in your favor because you would like to have a myopic error rather than having a hyperopic error. And using the calculations, that multiplication which I have also showed and Sir was also talking about, of 1.7 or 1.8 comes very, very handy. And having a good retinoscopy, like somebody who can do a good retinoscopy in your center is
there
very
is a
crucial.
difference what we are talking. We are talking of the intraoperative.
Yes.
I am talking preoperative. In an average eye, the IOL power needed is 21. If the patient is hyperopic by 5 diopter,
Yeah.
so the same 1.7 or 1.8 you multiply, add into 21. So it's very difficult to do the intraoperative refraction and then try to calculate. So, and secondly, whenever you do the piggyback IOL,
Yeah.
or when you're adding on, it is 1.7.
Yes.
Otherwise, even 1.7 as Maloney will not hold true. Just I'm coming to the point.
Yeah.
Reason is, we have done a lot of cases in a camp, and normal IOL required is 20.5 or 21 in the Indian eyes. And while after leaving the patient of phakic, patient needed plus 10 or 10.5. That means whenever there is absolutely no lens inside the eye, it is the multiplication factor is higher. It is reaching nearly 2. So whenever the refractive error is more, even multiplication factor is also higher. As compared, if patient has got 2 diopter of refractive error, you can multiply by 1.5, there is no problem.
Yes.
If patient has got 8 diopter of refractive error, you will have to multiply with a higher factor.
So the only one thing that probably I'll not agree with you will be about the preoperative refraction when the cataract is still in the eye. Because when the cataract is still in the eye, the nuclear changes in the cataract is going to change your refraction. It is also going to change your astigmatism significantly. And if you take the axis
So
of the
most
preoperative
of these
refraction,
patients
make
are
all issues.
myopic.
Yeah.
They always come in a very early stage, are not yet operated, a post-RK patient who has gone into hypermature cataract stage. And secondly, all these patients have got a history along with them. They are very clever. They will give you all the sheets of the refraction they have been using over the period of time.
Yes.
So even you can find out whether it's a nuclear sclerosis changing or their refraction is stable, what it was there. So you'll always find out in a post-RK patient or post-LASIK patients, they never come too late. There's always a immature cataract.
Yeah, so the prerequisite here is that you should have the history of the patient very well. Even patient has developed the cataract. Because many times these patients will come to you after they have developed the cataract and done the refractive surgery somewhere else. So I think, yeah.
They have got their spectacles along with them.
Yes.
I think, Vardhaman, there's just one other thing that in my hands, in my experience, the Barrett's True K works a lot better than the high gaze. The high gaze
Yes,
is
yes,
a K independent formula, all right, but it has just too many variables when it comes to the A constant. It's not easy to compute the A0,
A0,
A1,
A1,
and
A2.
A2.
Very true.
So
very
high
true.
gaze is one of the best formulae to work with, the pre-Barrett's era, if you have all the parameters with you.
Absolutely.
Because there's just too many variables which we don't have any clue about.
Yeah.
And for intacs, I actually don't change the formula at all because it doesn't apart from flattening the cornea, it doesn't actually change the shape or the contour of it. So you can go ahead and do it in a normal way. For the post-RK, however, if we are trying to correct the astigmatism in particular, most of the time, as the topography would reveal, they would not have regular astigmatism. So if the patient has a history of using glasses for the astigmatism and the patient is happy with it, I would much rather put in a spherical IOL and ask the patient to continue wearing glasses to correct the astigmatism and not
think the
try to correct
regularity-
it with torics.
Regularity of the cornea is very crucial in
If the
pentacam.
patient is happy with the cylindrical correction, he'll be happy with the cylindrical correction, the IOL as well. So the cornea is so distorted, so when the patient uses spectacle in whatever axis, the same axis will work in the IOL. So next time you try it out, and most of the patients usually will find will come within 0.75 to 1 diopter. If you correct by, I have used +9 diopter of the power and corrected 6 diopter of astigmatism in these patients. Leaving the patient 5-6 diopter astigmatic is not the option.
Yeah, I think every case in these cases have to be done with individualistic approach.
Individual.
Yeah, yeah,
Vardhaman,
yeah.
yeah.